For everyone with an interest in NASH or more broadly fatty liver disease, Surf's Up. Season 4, Episode 36 of the podcast still known as Surfing the NASH Tsunami, at least for now. Our look at the highly innovative LOCATE-NAFLD trial run in Australia with one of the key co-authors, James O'Byrne, starts now.
This week on Surfing the NASH Tsunami.
A disease this common, we need to find ways to expedite referring patients at risk of having more aggressive disease.
This model affords you probably a year's advantage in terms of diagnosis of your stage of liver disease. As we move into the era of effective pharmacotherapy for NASH-NAFLD, a year could make a big difference in terms of the stage of disease and fibrosis.
The easier the technology is to train and get consistent results on, the better off we're going to be.
Anybody referred to a liver pathway should be able to get their FibroScan and into specialist care in a triage.
Every week, a global community of fatty liver disease stakeholders comes together to explore the most important challenges in diagnosing, treating, and developing medications for patients with fatty liver diseases. Join liver wellness advocate Louise Campbell, pricing and forecasting guru Roger Green, and their guests, hepatology researchers and key opinion leaders Dr. Naim Alkhouri and Professor James O'Byrne, as they review recent research from Australia on the most effective and efficient ways to locate fatty liver patients and enroll them in treatment on Surfing the NASH Tsunami.
There are a few things that are really different about this episode. For, I believe, the first time in the podcast, I am on an episode with somebody from Australia that is not Louise, which means that we have people on this podcast at 8 in the morning where they live, 5 in the afternoon where they live. And Louise, what is it, 10 o'clock at night there?
Yep, 10 o'clock in the evening here. I think it's 7 a.m. where you are, James. I lost track of where Naim is these times.
Naim is in his new home in Ohio, so he's at the same time zone I am, 5 in the afternoon. Naim, how are you today?
I'm good. How are you? It's been a while. Glad to be on the same time zone like you. This is not often that it happens, so good to be on Eastern time.
Yeah, good to have you here, and welcome back to the podcast. You and I have been talking about a couple episodes over the next couple of months that you'll be part of also, which I'm excited about. And then our guest from Australia, and I guess the other thing that's odd about this is that it was easy to guess that we would be talking about two of the people on this podcast having teams still playing in the Women's World Cup, but we would have guessed that I was one of them, and I'm not. However, James O'Byrne, who is also a dual Australian-British like Louise, has two teams playing, I guess. Good afternoon, James. How are you today?
I'm very well. Thank you very much, and thank you for inviting me onto the podcast.
And welcome to NASH Tsunami, or soon be known, I think, MASH Tsunami. James is also unusual in that we do not usually have people with three-dimensional replicas of livers over their left shoulder while they're talking to us. And if you can get the video on James, he's got that in the background as well. So, James, before we get started, please take a minute or two and tell our audience a little bit about you, your background, what you do now, how you came to be doing what you're doing, where you're doing it. And then I'll have one question for you when you're done with that.
So my name is James O'Byrne. I'm a consultant hepatologist and clinical director of hepatology at the beautifully named Sunshine Coast University Hospital in sunny Queensland in Australia. I was a transplant hepatologist by trade in the UK. Funnily enough, I started my medical career on the same ward as Louise when I was a house officer many, many years ago. I'm not going to mention how many. And I worked through many of the liver units in and around London. And then 2015, in the Brexit referendum, I voted to remain, and then I left and came to Australia, where I am now, and I'm very happy, and I'm in charge of the clinical trial portfolio here at the Sunshine Coast.
So is Queensland as sunny as your name implies when you say sunny Queensland?
Absolutely. So we're in midwinter at the moment, and it's about 23 degrees Celsius during the day and sort of 13, 14 in the evening. So very much shorts and T-shirt weather all year round.
Sounds like Miami.
Yeah, well,
very nice.
There are some similarities.
So the other thing I'd like, if you could, we ask everyone who comes on for the first time to share one fact about yourself that folks wouldn't know if you didn't choose to share it with them. Something that's a little bit out of character or different.
Okay. I suppose many people wouldn't know that I have a thing about long distance cycling. And a few years ago, I cycled the length of Britain from Land's End to John O'Groats over 9 days, over nearly 200 kilometers a day. and thoroughly enjoyed it.
That's the thing. You know what? I don't believe we've ever had, I think you are the first person to discuss long-distance cycling as what makes you special. I thought you might become the second person from Australia to talk about having played rugby, but I like this one a lot better. That's great.
Well, the way the Wallabies are going at the moment, we tend not to mention rugby too much.
Did you do it for fun, James, or did you do it with a charity? Because that's a long distance.
I did it for fun.
Well done.
It was a challenge, but cycling across Scotland will remain with me forever. It's absolutely beautiful.
That's fantastic. That sounds like a wonderful thing to have done. So with that, icebreakers for the gang before we get started. One good thing, personal or professional, that's happened in your life in the past week. Brave one, go first.
Oh, I'll be brave, but I'll stick to the World Cup theme. The fact that England got through by the skin of their teeth today. The Lionesses, both you and Jean's teams fell by the wayside this week. So we're 1 and 2 gone.
It's true. Okay, Naim, what you got?
So I enjoyed my summer. So my sister and her family came from Dubai and they spent the summer in Phoenix. So we went to San Diego, Santa Monica, Flagstaff, Grand Canyon. They came from Dubai thinking that Arizona is going to be dry heat and nicer, but we had the hottest summer on record. We were above 110 degrees for 31 consecutive days. So that was not pleasant, but I would say we had a very good summer with the family.
That's great. What is the temperature normally in Dubai this time of year? Just for those of us who don't know.
105, but also it's like 200% humidity. So very difficult to be outside. You can't even breathe.
Yeah, it's better in Phoenix where it's a dry 115, although I've got to tell you, I've been in Phoenix when it's 115 or if you will, 45 for those in the rest of the world. And that's a temperature at which nothing saves you. You know, they say it's not the heat, it's the humidity. At that temperature, it's the heat. So James, what's your good news from the past week?
Well, I'm going to be very boring and say really good news. We had a paper accepted, which is always good. But really, what I'm really looking forward to is in 3 days' time, I fly to Tasmania for a week. And I'm looking forward to a real gourmet food wine experience.
That's interesting.
So you thought you'd go deeper into winter. It is cold down there at this time of year.
Exactly right. But being from the UK, I have all the clothing that's just sort of sitting there in the wardrobe doing nothing. So it'll be a chance to... and there's no such thing as bad weather. It's just bad preparation, right? So I'm looking forward to it.
Yeah, begging to differ, there is such a thing as bad weather, but bad preparation really makes it a lot worse. I agree with that. Occasionally, winter around here, it gets down to about 15 or 20 below. And that's...
Oh, yeah.
Tasmania
is not that bad.
All right, so I'm gonna follow James's theme, which is this Saturday I pack up and go to the Jersey Shore for 2 weeks for my annual 2 weeks there, and we will have my son and daughter-in-law and granddaughter with us for the first week, and an assortment of friends for the second week. I'll be doing the podcast next week. I will not be doing it the second week. Jorn will be back, and I'm tremendously looking forward to it. It's just a great place to go spend time and great memories. My wife and I were married there years ago, and it's just a place I look forward to with tremendous fondness. So with that, why don't we dive in? Louise talked about this episode last week when we talked about the 2 episodes Louise wanted to bring forth for the month of August. So Louise, I'm going to invite you to remind everybody why you were excited to do an episode about this paper. And then we'll ask James to start talking about the study.
Great. And it's nice to have James with us. And as he said, I was a ward sister on the ward he first became a house officer on. So we go back a long way. But we're both babies, really. We just happen to now work between, I work between the 2 countries, and James works obviously all the time now in Brisbane and Queensland, which I was in about 3 weeks ago. I was up in Cairns and I drove across the entire top end. So I've been on some of the outback roads to Borroloola and places like that. So I know we can get a FibroScan in there. So this is one of the reasons when I looked at your study, it excited me. And I think this was about a year and a bit, when we were sort of looking. And I think it was the fact that what excited me more than anything is that you're looking at 2 different pathways, both randomised, and one was including FibroScan at the local sourced area where the primary care physician is, in a country that doesn't Medicare reimburse FibroScan yet, so it's actually not as easy to do as some people would recognise. You've got to put it in that pathway. And how it was, also the fact that it was patient or focused on their outcomes, quality of life. I think you've got multiple measures, which I'm sure you're going to go on and talk to us about. And I think it was that holistic approach, but also that you were going to do some sort of statistical analysis and economic breakdown of what did it mean. And I think it's more important now for me, and where we sit within the podcast, that NICE, the National Institute of Care Excellence in the UK, have approved FibroScan at a primary care and secondary care and non-specialist setting, they call it. But we haven't got a pathway. Most of our pathways still sit within trials or pilot projects. So whilst it's been released, we don't know the exact pathway it's going to follow and which is going to be the best, and different areas may have different ones. So this is why you revealing some of your information today and talking us through the protocol interested us when we were thinking about it. And I can't think of a better person to have on the podcast than Naim to be looking at that at the moment.
Well, thank you. And thank you for the opportunity to share our project. I would say that the data that we're going to discuss is as yet unpublished, but I have the permission of my co-investigators, as this will go to preprint very shortly, to share the headline data from our trial with you. But let me go back to just maybe where this started. So as I said earlier, I came across to Australia in 2016. And what I found at that stage was that Australia had just allowed open access, if you will, to DAAs for hepatitis C. First country in the world to allow these to be prescribed by primary care providers, not just hospital specialists, and really unrestricted access to these drugs, which was coming from the UK, which was remarkable. And we faced a wonderful problem in a way, in that we had all these patients with hepatitis C, a lot of them with cirrhosis, and they needed to get onto treatment. And at the time, there were different regimens depending on whether you were cirrhotic or non-cirrhotic, and we needed a way of determining that and to get people through treatment. And of course, at the time, the primary care physicians were sort of unskilled really in treatment of hepatitis C, so we were flooded with referrals. All of these patients needed a FibroScan, so we came up with a scheme that we called the Hepatology Partnership, and we put in for some money to get 2 mobile fibroscanners with a nurse that was funded. And rather than actually put people on a waiting list to come and see us in the hospital for a FibroScan and then a prescription, we would send our nurse out to community health clinic, GP practice, other hospitals, sometimes across the whole region, which went up to, you'll know, Louise, and the geography of the area. We sent people, nurses up to Bundaberg, which is 800 kilometres away, to do the FibroScans. And then we provided a report to the GP saying, this is your patient, he's got genotype 3 hepatitis C, non-cirrhotic. This is the treatment regimen. We've done all the checks for you, and the GP would then prescribe the medications. And we treated over 2,000 people, I think, in the first sort of 2 years of that project. Enormously successful. And then we thought, well, we better actually sort of share some of this data and get it published, which we did. And I engaged some colleagues at QUT, the Queensland University of Technology, to do an economic analysis. And that's what formed the kernel of the LOCATE-NAFLD group, because having done all that work with hepatitis C and really broke the back of the hepatitis C problem in Queensland, in our region of Queensland, we then sort of said, well, this is actually quite a good model of democratizing access to this risk stratification. And could we look at another disease state? And obviously NAFLD or MASLD came to the fore. We learned from the mistakes of the past. I mean, I'm guilty of sort of charging into things headlong, and looking back at the analysis of the hepatitis C data, there's lots of things we wish we'd done differently, because we sort of did it more of a sort of a reaction rather than a proactive thing. So when we started tackling NAFLD, we said, right, let's do this properly. Let's do it as a randomized trial to prove that this model of care has benefits. Let's link it into some qualitative stuff to see that the patient experience is good. And let's make sure that our primary care physicians are on board as well. So we'll get some focus groups and see what the primary care physicians think about the model, and look at quality of life and costs, etc., and so on. So we put together the group, which involves myself, co-collaborators from University of Queensland, Queensland University of Technology, and we've got statisticians, we've got the health economists, we've got clinicians, and a couple of nurses. And that's how LOCATE-NAFLD started. So LOCATE-NAFLD is the local assessment and triage evaluation of NAFLD, and it's a randomized parallel controlled trial of patients referred in for assessment in secondary care by their general practitioners. And they were randomized at the point of referral to either the intervention, which is a nurse goes out to a community clinic or the GP practice to perform a FibroScan. Depending on the result of that FibroScan, they're defined as low risk or high risk, and the high risk patients were then re-triaged into secondary care and seen more quickly. The people who were low risk were discharged back to their GP with a whole load of advice and information about the management of non-alcoholic fatty liver disease, lifestyle measures, etc., and so on. Everybody was followed up at 12 months. And for the ones that were randomized to the standard of care, well, they had the standard of care, which was pragmatically they stayed on the waiting list until they were seen in a hepatology clinic and had their FibroScan. And the primary endpoint really was to, A, demonstrate that this improved the time to FibroScan, which axiomatically you would say, well, of course it's going to. And the second endpoint was whether the time to a diagnosis of high-risk NAFLD or advanced fibrosis was shortened. And then a number of other secondary endpoints looking at, was there an improvement in patients receiving access to dietetics, to exercise physiology. We looked at things like a recommendation for a lot of these patients was that they should receive a statin. So we looked at that as a binary outcome between the two groups. And we've just done the first analysis of the primary and secondary endpoints, which you might not be surprised are actually pretty supportive of the model. We chose a cutoff of 8 based on the high negative predictive value for that cutoff because we wanted to be able to safely discharge patients back to their primary care physicians.
So James, yes, just before we go on, Louise, Naim, questions you might have about the design or the background thinking on the study?
For me, I think the fact that it's a randomized trial, I mean, kudos to you guys. I think that's the right way to do it. And I think, you will answer the questions in a more scientific way. As you said, I have no doubt that it will lead to a rapid FibroScan and decreasing the wait time. The question is, this identification is going to lead to better outcomes, and that's a very difficult one to answer. I looked at the protocol. I know that you are looking also at liver-related outcomes, including varicose bleeding and ascites and things like that. And this is where it gets tricky because we're starting in the kind of PCP population. This is not an enriched population, lower prevalence of advanced fibrosis and cirrhosis. And then we know that the rate of outcomes developing is relatively lower in such a population. So these are, some of the thoughts I had. Obviously, the 8 cut point, it does have a decent negative predictive value. I don't know what assumption you guys used, but we're not talking about like 95% negative predictive value. So you will still probably miss some patients. And then the positive predictive value is also relatively lower. Many people that will be included in the what we call the high risk group will actually not have significant fibrosis. They may have F0. We know the BMI affects the accuracy of FibroScan. So several thoughts, but I like the randomization. I like the sample size. Of course, larger sample size, the better, but also you have probably budget and some restrictions on how many patients you can include. I think if I remember correctly, you guys planned on enrolling 238, which my mind was on the smaller end of things. But again, I understand where you're coming from. So these are some of my initial thoughts. But I think, again, this is very important because for a disease this common, we need to find ways to expedite referring patients at risk of having more aggressive disease.
I absolutely agree with all of those points. And we were hampered really in terms of the follow-up because we got an NHMRC grant to do this trial. And there's an endpoint to the study, which is sort of 3 years really after you get that grant money. So we had to be able to report. We do intend to follow up those longer term outcomes from with this cohort, assuming we get some further funding. As you know, these things, you need some results to be able to then build on and extend the analysis. We had to choose a cut point, and at the time, 8.2, 8.5, we thought we'd keep it quite simple. As it was, the two groups were quite matched, and about 27% of them fulfilled our definition of high risk. And you're right in that, the primary endpoint of the time to the diagnosis of high risk was dramatically shorter. So the median time from randomization to receiving a FibroScan and a diagnosis of advanced fibrosis or high risk, we can't really say advanced fibrosis, as you say, because of the positive predictive value, was 10 days. And at our 12-month follow-up mark, which is our planned sort of first analysis of longitudinal outcomes, 27% of the standard of care group had still not been seen in a secondary care clinic. So the headline is that this model affords you probably a year's advantage in terms of diagnosis of your stage of liver disease in suspected NASH/NAFLD. And in that time, you could argue, well, if you've just got lifestyle measures, a year is not really a big deal. But I think as we move into the era of, effective pharmacotherapy for NASH/NAFLD, a year could make a big difference in terms of stage of disease and fibrosis stage.
You said 10 days for the intervention group. What was the median median time for FibroScan in the other group?
So the median time for FibroScan in the other group, 266 days.
Oh my God. Okay. Wow. So I'm sure this was statistically significant with the p-value less than 0.
Naim, about the time James got to 200, and I figured we could have stopped and we knew the answer right there, regardless of what the last two digits were. Yeah, I'm sure that's right.
And just another follow-up question. Did you guys collect labs like AST, ALT, platelets? Are you able to calculate a FIB4 index, any other way to kind of increase the positive predictive value? And did you have any patients with cirrhosis that you identified?
So we do have all of that data. And again, that's going to be part of the primary analysis. So all of that data was collected at baseline and again at 12 months or when the patients were seen in secondary care. I would say that even though the low-risk patients we identified through the intervention, although we say we discharged them back to a general practitioner, we did, but we still had follow-up on those guys at 12 months for quality of life and things like that. So we do have longitudinal data in the entire group. Regarding the presence of cirrhosis, that was really defined as a sort of FibroScan reading of greater than 13.5. That was relatively small numbers, about 5% in each group. In terms of clinical outcomes, you're right, it's a very short time period for follow-up, although it's interesting that there were 2 variceal bleeds that occurred in the standard of care group within that follow-up period versus 0 in the intervention group. Now, that's really very small numbers, but it does tell you that within these groups, there are some people with pretty high-risk liver disease lurking there.
I think the interesting thing is, yes, it speeds up access to FibroScan, but if we were looking at this as a trial population, potentially, it speeds up the access to people to be able to be recruited to trials and some of the bigger trials. So I think this is the benefit of utilising this type of model. You use nurse specialists who were highly skilled in FibroScan.
Absolutely.
So I presume that they were giving information and reporting back to the patient at the time, so they were able to allay the fears. Now, just going back to that 10 days, it's practically impossible to organise a clinic anywhere in 10 days. So was that because the patients themselves got the information, or you might not know this data yet, but was it because they were empowered because they managed to get the data, they managed to get the referral, and they were seen? Did that engage them? Because some people go, oh, that's too quick, I must have cancer, and do the opposite.
So the randomization process involved a screening period. So when we received the referral, all referrals with suspected NAFLD were screened for inclusion in the trial, and then the trial nurses would ring suitable patients and say, look, we're doing this study and this is what we're trying to achieve. If you want to take part, there's the randomization means that you might actually get a scan to answer the question about how bad your liver disease is within a couple of weeks, or you can wait in the standard of care and the things. So I think patients by and large were quite keen and motivated to take part in the study. We had to get rid of a lot of patients who we screened because of high-risk alcohol use. So more than half people were screen failures. I guess, you could say our entry criteria were quite strict, but having proven that the intervention works in terms of identification of higher risk disease, you can safely expand that in further studies to come. So interestingly, in terms of the successful FibroScanning, and you say they were highly specialist nurses, well trained in FibroScan, they were also hepatology nurses, so they spent some time with the patients talking to them about their diagnosis, provided them with a copy of their FibroScan results and written information about lifestyle changes in non-alcoholic fatty liver disease, and that also was copied to their GP with some recommendations that for referral to dietetics, exercise physiology, pharmaceuticals, etc. So 98% of the FibroScans in the intervention arm were successful, and whilst it's open to interpretation, in the usual care arm, the standard of care arm, the successful initial FibroScan rate was only 77%. So there was a little bit of a drop-off, and I suspect that was because maybe in the clinics, people are coming and seeing maybe registrars who aren't perhaps as skilled as a dedicated nurse. As you know, Louise, if you're invested in the results and you know what you're doing, you can pretty much persist and get a decent FibroScan reading in most people. So we need to explore why there was a drop-off in successful FibroScans in the usual care group. What I was interested to see, though, is certainly at 12 months, there was no difference in the quality of life outcomes in the usual care versus the intervention arm. And I would have expected that people who had had an earlier diagnosis of either severe or high-risk liver disease, or indeed low risk, which is the majority, would have had an improved quality of life with one less thing to worry about. So we need to delve into that a bit bit more in our qualitative analysis with our patient focus groups and try and work out what the patient's attitudes are to a diagnosis of low risk versus high risk NAFLD.
That's interesting, because most people who have a FibroScan, and I don't know whether you've got the data, what we see, and Naim will be able to comment on it, is that they improve their behaviour and they reduce their liver fat, for example. And therefore their quality of life in sleep usually improves first, and then mood and energy levels. But you took CAP data. Are you able to sub-analyse the CAP data and be able to look at how many people improved within the 12 months? Do you have that yet?
We don't have that yet, because that again is sort of part of another paper, as it were. We did collect CAP on everybody, and we'll yet to analyse that, I'm afraid.
Because that'll be an interesting one to see whether or not that intervention and sort of improved those qualities of life. You're right about that with the nurses. When people have got more time in clinic, and this is the problem if you put it into a primary care setting where a doctor's only got 5 minutes, you're not going to be able to just do a test. It's going to add. So specialist clinics are probably definitely the way to go for me.
So, Louise, I was thinking about that as I was listening to James, and I was asking myself, so what do we infer from that for when you leave Australia and you go to countries that have maybe slightly larger specialty populations, but at the same time a greater push on clinical care pathways? The challenges in motivating primary care sites, and James made the point earlier, I think, or before we started, about in the presence of absence of drugs, that might be two very different phenomena. But I'm wondering how easy or difficult you envisage it being to motivate primary care sites, in the absence of medication, and how best to do that, and then how rapidly you think that would change for primary care, or the sites that were a little bit less motivated in the presence of medication. And James, I know I'm asking you to speculate wildly, but what the heck, it's a podcast.
Yeah. The future I see of this type of model is, I think it needs to be run by dedicated secondary care organisations or teams reaching out from secondary care centres, rather than really giving it the whole responsibility to primary care. I think that works for a primary care level. It works, for FIB4, say, but we know now from a couple of papers that FIB4 doesn't work in your diabetic population, and you usually need a second stratification test. So I can see no reason why you wouldn't want to have it based in the hospital, reaching out to different primary care settings as a sort of standalone organisation, rather than because not every primary care practitioner is going to be able to have a FibroScan in the office. I'm sure EchoSense would love that, but the reality is I don't think that's going to happen.
I would differ from James slightly, obviously, because what we do is we just provide FibroScan into areas of Australia, into areas of the UK, so that you don't need to, I suppose. And one of my questions was, how much did this take away from your nursing resource to be able to do in 10 days? Because clinics we have here, we just can't release our nurses that time unless they're dedicated research nurses, which we don't have, which is what we try and encompass by saying you don't need that. So I've been up to Borroloola. I know I can put a FibroScan clinic up there. I can put one in Hell's Gate Roadhouse. I know exactly where it is and how to get there, and most people do. But there are certain ways. But I think if we were to talk about other countries, you were talking about clinics there that were 800 kilometres away. When we talk about doing this in the UK, we're not talking about doing anywhere near that distance, but we seem to struggle on the concept of we can provide this into primary care without it being too difficult. I think for third world and lower income countries, I think where you can upskill, if you don't have nurse specialists to be able to do this, but dietetics, dietitians, and skilled practitioners in different ways, then it's something that can be utilised if we don't have the physicians to be able to do it. The potential to roll this type of model out into big distances or concentrated populations with community hubs, for example, what you've shown, that you can do that quite quickly with a precise mechanism to do so. Was that right?
Yeah, well, absolutely. And I quite like your idea of empowering the dietitians. Be quite a good thing, part of overall metabolic health, wouldn't it, when they do their measurements, to just do a FibroScan at the same time if they had access to it. I quite like the idea of having those sort of metabolic health hubs. Would probably be quite good, both for diabetes and obesity.
Naim, you go out, don't you, with your FibroScans? How do you find it?
We have a free FibroScan program. We advertise in the Phoenix and Tucson areas. Any patient can call a certain number and get a free FibroScan. We try to focus on patients with type 2 diabetes, obesity, people, at risk for muscle. We also partnered with PhD at the University of Arizona in Tucson, and he goes to mainly Mexican-American families, and they actually scan the entire family as part of a program called Nosotros. And I think the uptake has been great. And what they do, they utilize the same cut point of 8 kilopascals. And these are the patients that come to my clinic. And then everyone with values less than that, they reassure them and just provide some counseling about lifestyle intervention and managing metabolic syndrome for the most part. And patients like it. I think we identify some good candidates for clinical trials this way. I think it will become definitely more relevant when you have FDA and EMA approved medications where you can actually, and people that fail a lifestyle intervention, start a medicine that can potentially change the natural history of the disease. We are working also on having our own Arizona Liver Health minivan where we can do the FibroScan but also test for hepatitis C and B. So it's kind of like a comprehensive liver testing station. So we'll see. That should be happening next year. We also started some viral elimination centers. We, go to community events. We test for hepatitis C and do FibroScan to screen for NAFLD. So I think there's definitely appetite for all these outreach activities, and we've had good success with it.
No, that sounds excellent. And I think you're right. It makes sense, doesn't it, to get the FibroScans out of the hospitals into these at-risk groups, especially diabetes. We've got another project looking at FibroScan in community diabetes clinics, with staggeringly high rates of people with advanced or high-risk FibroScan readings. So the one thing that we wanted to do, and the reason why this is a randomized trial, is because all of this is going to cost money, you need to be able to do the RCT to show that A, it works, and B, then you can do the cost effectiveness analysis to show that it's cost effective, which I'm sure it is. We would hope that we will have that data, very soon and be able to sort of put some flesh on the bones of this primary analysis to be able to show that. And then we can start funding all of these programs and get them, rather than being exemplars of great practice, but to become business as usual.
It's a little bit tricky to establish cost effectiveness even when we have FDA approved medications, because it's going to be conditional approval based on histology, and we will not have the outcomes data for a few years after FDA approval. Part of me, I worry about, over medicalizing certain populations, especially with the issues related to FibroScan. And there is definitely some documented stories about, doctors going in the community offering screening programs that will lead to unnecessary procedures and interventions. We just need to be aware of this and also realize that even if we have an FDA approved medication next year, that it's really difficult to establish cost effectiveness until we understand how this affects the natural history of the disease. It doesn't mean that we surrender and not do these things. I'm just saying that we need to be aware of the limitations, and every test has issues. I mean, we're talking about FibroScan, elastography. Obviously, there's competing technologies that may become cheaper in the future, whether it's VeloCure or the hepatoscope or, even a basic ultrasound machine that has elastography capacity, but also some of the serologic tests like ELF and potentially the NIS2. I think these may also help streamline it. And then just realizing that you just need to have access to one of these technologies. And, at the end of the day, this is a pathway to expedite referral to a specialty clinic that will do further investigations. So I think, just some points to keep in mind.
I agree with that, but I would also say that some of the cost effectiveness comes from being able to reassure people quickly that they don't need further assessment in secondary care, and you will save all that cost of that ongoing further assessment and testing, etc., including the opportunity costs of people having to take time off work to come to a hospital appointment and have essentially a procedure or testing that can be done very effectively and quickly in the community. So I think there's definitely cost effectiveness to be had in that setting.
So how did you get over the Medicare issue? Because it's not Medicare refundable. So therefore, Are the patients paying, or are you paying per scan as part of the trial?
Well, this was part of a trial. The patients don't pay anything. There's one problem. I suspect if FibroScan was ever Medicare rebatable, then you'd probably find that every private gastroenterologist in Australia would have a FibroScan machine, but it's not. So that's why it's traditionally been limited to the public hospitals, which obviously that then restricts access, really. So that's one of the reasons why we developed this model. So the patients didn't pay anything and we didn't try and get any rebate from Medicare.
Clearly, if you're doing a 10-day versus a 266-day follow-up, you should find a significant difference. Does the model set up to start to do a better job of calculating where the sweet spot might be economically?
I think I'll leave that to Dr. Brain, who's our health economist. Beautifully named, Dr. Brain. So, yeah.
It is a great name. It's the second David Brain I've read of in my life. And the two people I've read of who are in my public life who are named Brain, both first name were David. That's a coincidence, but go figure. Because obviously, when you start start to work out the UK has just made a significant investment in creating scanning in public centers to increase the frequency of scanning. But I'm figuring that the results of this study will actually have a lot to do with how Australia decides to proceed on that.
We hope so, and I think that's why it was funded by the NHMRC, because I think they wanted an answer to this question as well.
I think it's important because there's not a lot of Australian-based studies that give us the data. It's one of the things that I hear a lot in WA, but where's the Australian data? It's a lot, as James will know, that NICE, it's only English data that is considered. So I think it's important to prove the level of NAFLD in Australia, the associated conditions, because 3 of their biggest conditions are alcohol, cardiovascular, and diabetes, and now we know they're all intrinsically linked. So anything that we can tease out of that study in Australia will evidence base for the politicians and the primary care. But just thinking of primary care, you did mention that you received a few more referrals from primary care as a follow-up. Do you think that's because they were better educated because of the information that was being sent back? And were they sending you better, more accurate patients rather than others?
Yes and no. We did see some uptick in quality referrals, but not as many as I would really like to have seen, because, when we pretty much had patients coming from every sort of local practice, and with the information that we sent back, was quite robust and thorough. I guess maybe we overwhelmed some of the primary care practitioners, but we did see some people coming back with specific requests. I've got this patient, I think they've got fatty liver, they've got steatosis, can they have a FibroScan? That's great. We were still getting some referrals from the same practices that were sort of, I've got this patient with a ferritin of 500 and a mildly abnormal ALT, they've got a BMI of 38, please can you see them? I don't know what's going on. And that was sort of slightly disappointing in a way.
It's interesting because Predictive Health, who analyse data, would say that only 10% of abnormal liver function tests and people picked up are actually acted on by primary care. So you're the tip of the iceberg.
And then we know from our diabetic studies that you can have completely normal ALT and have significant fibrosis in the setting of type 2.
So to all of you, one of the questions that's kind of sticking in the back of my head as I listen to all this is about geographic dispersion. That one of the things that makes Australia different from the UK or the US or most of the US is the vast size and the relatively small number of people. So, so James, when you made the comment of every private gastroenterologist in the country would have a FibroScan, I'm wondering what the effects of geography are in terms of implementing the results of a study like this. And Naim, I'm looking at you also because you've got a location in Ohio and a location in Arizona. And Arizona is Phoenix, Tucson, and a lot of dusty road between the two. The Cleveland area is a lot more geographically compact. So I'm kind of wondering, particularly as we start to push into primary care, what the impact of geography will be on all this. Anybody have a thought on that?
It's a real problem. So when we did our hepatitis C work, we were very lucky to have an absolutely fantastic nurse attached to the project who would drive up to Bundaberg and do like FibroScan clinics in community clinics for patients with hepatitis C, and then stay overnight in nurses' accommodation at Bundaberg Hospital, and then drive back the next day with the mobile FibroScanner in the back of her car. You can't expect that of most normal people. So for the purposes of the NAFLD, we're not going to be able to do that. But I would have thought that if, having proven that the intervention sort of shortens the time to diagnosis and seems to be good for patients, then, there is no reason why a nurse based in Bundaberg or wherever it be, 800 kilometers away, can't do these clinics and then feed back the results to a hepatologist remotely for decision making in a sort of MDT type fashion, and then they feed back the final results to the primary care physician. So the geography is challenging, and I used to think that looking after patients post-liver transplant was difficult, but you want to try and look after people with diuretic refractory ascites who live in a caravan park 400 kilometers away. That's real challenging hepatology.
Yeah, brutal was the word that came to mind. Naim, you made a comment before I'm interested in that it seems to me that in the situation that James just described, the easier the technology is to train and get consistent results on, the better off we're going to be. So you mentioned Vellicur and e-Scopics as options or basic ultrasound. It feels to me that in that setting, one of the things to evaluate the different technologies on is how easy is it to train to consistency, because you're not going to have a lot of supervision. Does that sound right?
Yeah, I agree. I mean, it's nice to have these dedicated people that do all these heroic efforts to travel the country and sleep 5 hours a night, but this is not sustainable for a disease that affects, 35% of the population. So we need the simple technology that's cheaper. I mean, the cost of the FibroScan machine has been one of the biggest hurdles, and I think we need a handheld device that costs between maybe $5,000 to $8,000 that you can actually give to most primary care offices, something that will give you consistent results referrals, and then you can do this mass screening, and then blood test. I mean, you can do a blood test anywhere. We have to keep this in mind that, we can't rely on imaging only.
So all that makes sense to me. And I guess by definition, liquid biopsy is, well, let me ask, how much more consistent are the results of liquid biopsy compared to imaging? So that if what we're talking about is being able to get consistent results out of populations where the density doesn't speak to having a lot of physicians, can we get that better out of an IS2 or out of an ELF than we can out of imaging machine?
I mean, I think a blood test is possibly more scalable than an imaging machine. It depends on the availability. ELF is not a cheap test at this point in the United States, so it has limitations, and it doesn't work in all patient populations. It's affected by things outside of the liver. So I think we need everything. We need every tool that we have. It's not going to be just one machine or one blood test, but I think we need the combination.
I agree. I mean, ELF isn't funded here. I mean, I've got some experience with ELF and it's helpful, but as you say, all of these tests have their own limitations and caveats. The one thing, though, about a blood test, and maybe Louise will comment on this, is that the process of doing a FibroScan, that interaction with the patients, nurses will often report that it's a therapeutic intervention as well as just getting a result. So it's the real-time interpretation of what that result means for that particular patient. You can show where they are on a chart in terms of what their CAP score means. So I think there's a bit more value added to a FibroScan or an imaging technique than just a blood test.
No, I think you're right, and we discuss that here all of the time, and everybody who uses it knows that it's a brief intervention. It's not coded, it's not costed as a brief intervention, but if you use somebody who's highly skilled, and particularly your hepatology nurses were, and I think that's where we operate from, it's about the information and the moment, because you can see the moment in the eyes, you can know what they're going to say, but to have that interaction. And I think if we're looking at sustainability as well, it is easier to take a FibroScan to Bundaberg than it is to bring a dozen patients down from Bundaberg. It's easier to do these things, and we are now moving into sustainability and how we do that. The ability to turn around clinics quite quickly is a positive. I think upskilling, and I think EchoSense would say that the most densely populated FibroScan per head of the population is in Australia, because of course most of the population sit on the east coast. Most of the centres are in Sydney, Brisbane, so density of population per head, and FibroScans, Australia is the biggest, well provided than anywhere else in the world. I think that may well still be the case, but it's about how often do they get used. Your trial didn't use continuous cap and it didn't use smart depth, which makes it better for people of larger skin to capsule distance because it measures deeper. You get a better and a more accurate reading these days. So there are technology advances that can bring FibroScan better, but none of the trials currently have used, that I'm aware of, Naim will know more, that have used continuous cap and smart exam. So all of the evidence that we're currently looking at are older machines with poorer technology, but we can put them in anywhere, and it is about the skill set that goes in there. And that's the one thing that surprised me about the evidence that you've related, that only 77% success rate in a clinic in a hospital against 95, I think you said.
About 99 of it.
99%, which is what I would expect to get. If you're a specialist nurse or highly skilled in that test, you shouldn't be removing the tests. You should not be able to get them.
Yeah, you're right. And we mentioned other imaging techniques and other forms of elastography. I don't know whether other people have this experience, but I find that there's a hell of a lot of variability in when elastography results I get from shear wave and other techniques when I compare them to what I consider the reference, which is FibroScan. I don't know whether other people have had that experience.
So Naim, I'd love for you to comment on that.
Yeah, definitely. I get this consult, I would say once a week, where someone had an ultrasound with elastography and they're told they have advanced fibrosis, sometimes cirrhosis, and then we do the FibroScan and we get low values for liver stiffness like 5 or 6. And then it becomes a question in my mind, well, which technology is more accurate? I cannot tell the patient that my FibroScan is definitely better. Then, we start looking at the entire clinical picture from the platelet count to the FIB4 to the spleen size. And usually I do another test like ELF or MR elastography. And then if I have two NITs pointing in the same direction, I tend to believe the two consistent ones and disregard the one that is an outlier. But to be honest with you, I think it's more operator dependent. So this is a bigger issue for me in Arizona compared to my previous location in Texas. So it is a common scenario that we deal with.
I think people have to remember the position of the liver when they take a FibroScan or a shear wave. If you are towards the upper end, so the top, or to the bottom, the liver is stiffer. So you can actually find stiffer tissue depending on where positional. So you are trying to get a FibroScan scan in the middle portion of the liver. And to be fair, if I get a stiff reading to start, I will try and move that FibroScan down, because what I'm looking for is the consistent soft tissue. If it's hard all over, then that's consistent. But actually, if a smoker, their lungs push their livers further down, it is not just point and shoot first time on somebody you've never scanned before. You do have to take all of that into consideration, but you are trying to find the middle portion of the liver, which is a consistent elastography, rather than the outer margins of a liver, which are going to be stiffer.
Yeah, I just wanted to thank you for saying this, because although we think of FibroScan as operator independent, it is indeed, operator dependent. The experience of the operator is very important. And the goal is not to get 10 measurements with an IQR of 29%. The goal is, as you said, to scan the liver, find a good spot, take your time, and not shy away from not taking measurements that are not consistent enough. And then also, one thing we learned is that the patient needs to lay down for about 3 to 5 minutes before you do the FibroScan. If you just lay them down and start measuring, you may overestimate a little bit. This laying down for a few minutes allows the portal circulation to recalibrate, and you get a more accurate measurement. And of course, the fasting piece and not cutting corners. I mean, we tell people to fast for about 3 hours. We allow some water, maybe black coffee, but I've seen people have a big lunch and it's like 2.5 hours and everyone is eager to get the FibroScan. Why? Like, just say, okay, we can't do it today. Come back another day when you're fasting and get an accurate measurement. So just keeping all these things in mind and just realizing that these results will have great implications and may lead to unnecessary testing. So I'd rather repeat the scan or just do it another day than get, high values that are not accurate.
So one of the things I take out of the last 5 minutes of this conversation, though, is that as we start to make this more real and more consistent, we need to either upscale the level of training that we're giving the operators or develop machines that are simpler to handle, right? I don't know if the second one's possible. If I'm not a scientist, I'm clearly not a technology guy on this stuff, but it would feel to me that for us to make significant advances in health, we're going to have to become a little more consistent about this.
I think that's true, but we've got to stop saying that FibroScan is a simple test. It is a very simple test in the correct hands. It can be a very complicated test and a wrong test in the wrong hands. Like any test, it can be operator dependent, but we do know, we've done evidence that says you can do, as long as they're skilled and they know what they're doing, interoperator variability is actually quite good and very good. But actually where you don't have skilled users, now in the UK we look at around about 30 to 50 supervised scans before you're said that you're proficient. But we have one of the only regulated FibroScan systems in the world. Everything else, most of the world, it's not regulated. So there is no control mechanism on it. I'd like to see more control, but I work in a regulated society, so I have to produce all of the documents and prove my evidence to my regulators. But I would like to see a little bit more going in on that for that proficiency. But yes, I would love a simple handheld tool that I can just do and it removes all of that. But I think it will still be position on the liver dependent.
So one thought on that, and then we're going to close in question, which is because I'm really old, as I frequently confess. I remember a period of time back in the 80s and 90s and aughts, really 80s and 90s, when we would see new antibiotics come to market. And they would claim that for one reason or another, they had a superior resistance profile to whatever came before them. And it turned out the real reason was not enough patients that had them yet. So famously, the fluoroquinolone, ciprofloxacin, was originally marketed as being something that, because I think of plasmids, would never have a resistance issue. And once enough people got it, of course it did. So the analogy here being the claim that one technology will be less operator dependent than the other can only be proven out after a lot of operators have used it. And until then, I think your point about the dedication to training really is going to be pivotal if we're going to make this a core technology to what we do.
Can I ask one question that I have been wanting to ask? James, did you have a split? And if it was, what was the split between non-Indigenous and Indigenous Australians? So your Aboriginal Torres Strait Islander population.
So on the Sunshine Coast, we have actually quite a small Indigenous population. So we had two sort of main study sites. One was on the Sunshine Coast, which is sort of semi-regional, and then there was a metropolitan site. So overall, the number of Indigenous candidates was actually quite small, but equally split between the intervention arm and the non-intervention arm. But to be honest, the numbers are so small that I could not possibly begin to tell you anything about that, sadly, because I guess it's one of the things about the part of Queensland where we are, where there's a very low representation of Indigenous peoples, which is a shame.
So as we roll past the hour, final question, and James, I have a different question for you than I have for the others. My question to you is what's next? And my question to the others is, what do you take from this that will help you in what you're doing right now? now, either to implement differently, think about it differently, or just educate people better on the right thing to do. James, I'm going to ask you to go first on what's next, and then you guys on the other question.
Okay, so we still have some analysis to do for the primary outcome measures, but what's really next is to get into the meat of the patient experience, and we've already done a lot of qualitative interviews and surveys of patients in both arms, and indeed the primary care providers and what their experience is, because ultimately at the end of this, we want to be able to say the complete package is, this is an intervention that leads to an earlier diagnosis of advanced fibrosis or high-risk FibroScan readings. It's acceptable to patients, it's acceptable to primary care providers, and it's cost-effective. That's the next series of manuscripts, if you will. After that, I think we need to sort of see if people take it up and roll it out in other areas. We would certainly say that from our perspective, I think once we get into the realm of effective pharmacotherapy, I think it will be quite useful in terms of screening out those people who would be candidates for trials or even for a fully FDA-approved drug.
Okay, good. Louise or Naim?
Just listening to James, and again, congratulations again on doing this randomized controlled trial. At Arizona Liver Health, all we do is clinical trials, but usually they're pharmaceutical company sponsored. We do phase 1 to 3. I've done some investigator-initiated studies, but everything was comparing, therapeutic interventions. I haven't done anything comparing diagnostic interventions, and he got me thinking about designing some trials where you do head-to-head comparison against standard of care, but also between different NITs. You can have the ELF pathway, you can have the FibroScan pathway, potentially a new technology, and look at potentially outcomes and maybe having a gold standard that's more sophisticated test like an MR elastography or one of the MR-based scores, but then looking at these simpler NITs and really providing more accurate information on how they perform head-to-head so we can come up with the best NIT strategy. So I really appreciate being invited to be part of this episode, enjoyed the discussion, and got me thinking about some new directions, which is the best outcome you can get from a podcast. So thank you.
So thanks, Naim. Louise, go ahead.
I love Naim, and I love it when he gets thinking because I can hear him ticking. On a sort of secondary note to that, it is that whole thing of being able to take it out, because I now have a picture of Naim with a bicycle, with a FibroScan, a e-Scopix machine, things running, cycling around. Certainly, in all seriousness, it's that ability to get it out. You've shown a pathway for me that I use in Towers and Health, which is nurse specialist delivered FibroScans to any location, to be able to do exactly what you're doing. So I believe that that model does work. I believe it is more cost effective. I think on the back of what Naim is saying, if we're going to get people into trials before they're all treated with Ozempic or Wegovy and we're going to have anybody left, then we're going to have to go for a 10-day screening process to get them into the higher risk options. And I think you've shown a way that that could happen, to recruit into clinical studies, clinical trials. And I suppose what I'd like to see is if this protocol could be adapted for all liver disease, to get everybody with liver disease 10-day, whether it's alcohol, whether it's hemochromatosis, whether it's autoimmune, that anybody referred to a liver pathway should be able to get their FibroScan and into specialist care in a triaged. Can't wait. We'll definitely have him back for the outpatient formats and their experiences.
Yeah, I totally agree. As I've been listening, there's two thoughts that have stayed in the back of my head. First of all, the new nomenclature, Met-ALD. The mixed population is going to be really interesting to look at on this. Right, and that's just not a population we've thought about before, or we've thought about, but we haven't been able to.
It would have been fun. It would have been much easier to recruit into the study if we could have had Met-ALD as a definition rather than pure non-alcoholic fatty liver disease. Because in Queensland it's hot and we like a beer.
Every Aussie I've ever met likes a beer. Until they like too many and then they can't anymore. But that's a whole different question.
Bundaberg produce rum, so they like that too.
Yeah, well, exactly right. Exactly right.
Now you're on my speed, as you know. And then the second thought was the one we've been through already, which is this will depend to some degree on the consistency of operator or the consistency of result, which is either about operator training or it's about more easily operable equipment or biopsies. And Naim, that led me to exactly where you were, which is that one of the things I don't think we're evaluating enough right now is of the various techniques available to us, which will produce results most consistently against, as you say, MRE or the right kind of standard. James, this has been fantastic. I think it's been mind-expanding for me and for Louise and Naim. I hope for our audience, we have to have you back when you got more results on the patients of the qualitative. And thank you so much for joining today.
Oh, well, thank you very much for inviting me. I really enjoyed it. Thank you very much.
So let's everybody say goodbye. I'll be back with a business report in a few minutes. And for everyone else, we'll see you next week on the podcast.
And now for the Season 4, Episode 36 Business Report.
Slava Ukraini, Heroyam Slava, Glory to Ukraine, Glory to Heroes. Yesterday, the Washington Post editorial page focused on the incredible savagery the Russian military is committing against the Ukrainian people. The editorial was based on reporting from the Atrocity Crimes Advisory Group, a group established by the US, UK, and EU to document Ukrainian war crimes, or more to the point, Russian war crimes against the Ukrainian people. I quote the first paragraph of the editorial here. Russia's pitiless assault on Ukraine is a land grab, an imperial fever dream, and an unjustified war of aggression, but it's something more than that. It is also a relentless campaign of criminality aimed at eradicating Ukraine's national identity, spirit, and resolve, often by means of murder, rape, and torture. A sobering and horrifying statement, but it serves to remind us where the true evil lies in this horrible situation. Slava Ukraini.
This is a short report.
August is kind of a doldrum month, and I'm already planning my mid-month vacation. So we're still on the lookout for interesting and unique episode ideas for the fall, and the new website and branding are still in development. I'll have more news on both of those next week.
August downloads are off to a pretty good start.
This month is what one might describe as a cross-current. The July and June combination were by far our strongest 2 months ever and our strongest 2-month spell ever. But August is light every year. That said, the month's off to a decent start, and we'll simply have to track from here to see whether it looks more like June, July, or past August, or somewhere in the middle.
The Vault looks back 1 year to a different episode covering a similar topic.
It's ironic that James O'Byrne should start his discussion today referencing how Ian Rowe might consider the issue. 1 year ago this week, Ian joined Louise, Campbell, and me to discuss research he and Richard Parker conducted on the most effective and efficient strategies for early fibrosis detection. This week's Vault conversation centers around a theme that emerged in today's episode and that conversation. The idea that treaters are often challenged to bring asymptomatic patients with fatty liver disease back for return visits after an initial SLD diagnosis. For those who are not tracking the name nomenclature change, SLD, steatotic liver disease, is the new nomenclature for what has been described historically as fatty liver disease. So with that, I'm off until next week. Thanks to James for joining us at 7 a.m. his time, Louise for joining us at 10 p.m. her time, Naim for his usual and valuable contributions, and to Mike and Jake for their usual excellent work. Enjoy your weekend. We'll see you next week. Until then, stay safe, surf on. Bye-bye now.
Have any questions for the surfers? You can send them to surfingnash.com, and we will answer on the podcast or the website.